To open the next session, please welcome Professor Efren Domingo, Chair of the Department of Obstetrics and Gynecology at the Philippine General Hospital.
Good evening. I am Dr. Efren Domingo. I am Chairman and Professor of the Department of Obstetrics and Gynecology of the University of the Philippines, Philippine General Hospital in Manila. Tonight, it is my honor and privilege to introduce the lecturers. And the first will be on updates in gynecologic oncology, cancers of the cervix, uterus, and ovary. Our first speaker is Dr. Jae-Weon Kim. He is Professor of Gynecologic Oncology at the Seoul National University Hospital. He has been involved at both national and international levels in the field of gynecologic oncology for the last 2 decades and has been closely associated with the Gynecologic Cancer Intergroup, or GCIG, since 2004 as the representative of Korea. He is the current treasurer of the Asian Society of Gynecologic Oncology. Our second speaker is Professor Endang Nuryadi, an AOS counselor from the Department of Radiotherapy at the Dr. Sipto Mangunkusumo National General Hospital in Jakarta, Indonesia. He is a member of the Indonesian Radiation Oncology Society and the Southeast Asian Radiation Oncology Group. Ladies and gentlemen, please welcome our distinguished speakers, Dr. Jae-Weon Kim and Professor Endang Nuryadi. Thank you.
Good evening. Thank you for the kind introduction. I'm Jae-Weon Kim, a gynecology oncologist from Seoul National University, Seoul, Korea. Today, I'm going to talk about management of hereditary ovarian cancer in Korea. Here is my COI disclosure. And keywords of my topic are incidence has insurance system and policy of Korea, BRCA test, NGS panel test, RRSO, and PAP inhibitor. Here you can see the incidence trend of gynecologic cancer in Korea during the period of 1999 to 2015. Cervical cancer incidence decreasing, and ovarian endometrial cancer incidence is increasing. Again, and in 2019, the rank changed. Among gynecologic cancer, endometrial cancer is #1. However, if we add the fallopian tubal cancer and primary peritoneal cancer, ovarian cancer is #1, over 3,100 new cases. And ovarian cancer is not the #1 cause of death among gynecologic cancers. Here is a schematic diagram of the healthcare system in Korea. 2 points I would like to mention. We have a single payer, NHIS, National Health Insurance Service, covering 95% of the whole population of Korea. And second point, cancer patients pay only 5% of healthcare costs of themselves, although there are some exceptions. As you know, BRCA1 and 2 genes were found and reported in 1994 and 5. And in Korea, momentous events occurred in 2012 and 2017. A BRCA test reimbursement expanded to epithelial cancer in 2012 after BRCA testing reimbursement started as early as 2005 in breast cancer. And RRSO reimbursement started in 2012. And in 2017, family member BRCA testing, cascade testing reimbursement started. And gene panel testing and oropharynx reimbursement began in the same year. And as I mentioned, in 2012, the NHS approved and covering the BRCA gene testing and cost. for epithelial ovarian cancer and extended to tubal and primary peritoneal cancer from April 2017. Why is genetic testing important for women with ovarian cancer? For ovarian cancer patients, as we see in the SORO-1 trial results, maintenance treatment with olaparib after primary chemotherapy shows a striking advantage. 70% decreased the risk of cancer progression and death in BRCA1 and 2 mutation carriers who take the olaparib. The PFS gain is more than 3 years in olaparib arm compared with the placebo arm. And for their family members, the BRCA test offers the opportunity of cascade testing and prevention of developing ovarian cancer in affected BRCA mutation carriers. So in 2016, the Korean Society of Gynecology Oncology, KSGO, issued a position statement on a genetic test for ovarian cancer. We recommend the BRCA genetic testing in all patients with epithelial ovarian cancer. What is the optimal genetic testing strategy for newly diagnosed ovarian cancer patient? The first option is germline testing only. However, we can lose patients with a somatic mutation. The second option, tumor testing first, and then reflex to germline testing if tumor BRCA is positive. We expect detecting all BRCA mutations with these options. However, as we have seen in the SORO-1 trial result, the rate of missed BRCA mutation was 5%. Third option, both germline and somatic testing at histologic diagnosis is the best option. However, there are some technical issues to be tackled, and more importantly, the cost is the main barrier. The medical charge of the germline BRCA1 and 2 test is about $1,500 US. So in Korea, as I said, cancer patients pay just 5% of this cost. It will be $75 US. And cascade testing of patient family member is $100 US per person. And the turnaround time is about 2 months in our institution. And in clinical practice, it became more important to get BRCA test result quickly as possible, as we have to choose between bevacizumab, papillion, or both as a maintenance therapy after first-line chemo. Here you can see the germline BRCA test in patients with ovarian cancer in our institute during the period of 2007 to 2018. The number was nearly 400. And as you can see, from 2015, the number of patients to get this test is increasing. And the results, nearly 30% patients showed BRCA mutation. And germline BRCA1 mutation is 70%, and germline BRCA2 mutation is 30%. And 8% showed mutation of unknown variant of unknown significance. And among these patient group, 12% got breast cancer also, metachronous breast cancer. And among these, 24 patients showed germline BRCA mutation also. And among the histologic types, high-grade serous cancer shows the most frequent mutation positivity. And interestingly, we have checked the BRCA mutation status in mucinous type in 16 patients, And among these, 4 patients showed germline BRCA mutation. And we have checked the KGOG-based prevalence of germline and or somatic BRCA1 and 2 mutation in patients with high-grade serous and myeloid epithelial ovarian cancer. We perform the germline test first, and if this is negative, we perform a somatic NGS test. Here is the workflow and results. Germline BRCA1 and 2 mutation positive rate is 28%, and the somatic positive rate is as high as 12.5%. And not only BRCA1 or 2 genes related to hereditary ovarian cancer, but also BRIV1, RED51C, and RED51D, and the other minor genes account for about 20% of mutation carriers. The frequency of these genes in ovarian cancer is low, as 1.4% to 0.6%. So it is difficult to estimate the risk precisely. It is hard to counsel unaffected carriers of these genes. Anyway, in NCCN guidelines, carriers of these 3 genes, BRIV1, RAD51C, and D, regarded as having increased risk of ovarian cancer, and recommended should be considered on the RRSO at 45 to 50 years of age. To detect mutations of these genes, we need to have an NGS test. So in 2015, the NHS approved covering the cost of somatic NGS for ovarian breast cancer and germline NGS for hereditary cancer. Patients pay, in this case, 50% of the cost, approximately $650 US. In our hospital, we have 5 kinds of NGS panel. Among these, usually use first case panel. In this panel, we test these genes shown here, including homologous recombination deficiency genes described here. There is actually no limitation in sample types. We can use fresh frozen tissue and FFPE also. So now, turnaround time is less than 2 weeks. This is the sample of reported documents. Let's moving on to the next item, RRSO, risk reducing self-finger oophorectomy. RRSO procedure was approved and cost covered by insurance in BRCA1 and 2 mutated population since December 2012 in our country. And in women with high risk of developing epithelial ovarian cancer, such as BRCA mutation carriers, RRSO is the definitive surgical measure for preventing ovarian cancer. So again, KSG recommend BRCA carriers should be considered about risk reducing bilateral self-finger oophorectomy, ideally between 35 to 40 years, and upon completion of childbearing, or in an individualized manner based on the early stage of onset of ovarian cancer in the family. Usually we perform RRSO through single pore surgery, so this remains no visible scar. And in the clinic, we recommend RRSO procedure to unaffected BRCA pathogenic variant carriers, but the acceptance rate is not so high, so around 30%, as seen in this report, and mostly half of them want surveillance. That may be a practical issue. And usually they worried about surgical menopause after RRSO. And as you know, premature surgical menopause is associated with worse quality of life, worse cognitive function, and increased risk of bone and cardiovascular disease. So if RRSO is undertaken before natural menopause, Hormone replacement therapy should be considered to minimize these complications until the time of natural menopause. An HRT user after surgical menopause worried about the increased risk of breast cancer. Here is a subject on this topic. It's a prospective study of 872 BRCA1 carriers, 10 years follow-up data, and breast cancer incidence in never user of HRT versus ever users. Compared, there was no difference of breast cancer incidence, around 10%. So HRT use after oophorectomy was not associated with an increased risk of breast cancer. We can assure patients that in this situation, HRT is safe and necessary. And overall, estrogen left side graph, estrogen alone versus estrogen plus progesterone, there is no difference. However, if the oophorectomy performed before the age of 45 years, estrogen and progesterone combination shows the possibility of inferior results, but the sample size was small, so it's not conclusive one. It's a warrant for the study. And the other point, even after RRS or peritoneal carcinoma can develop. So in this retrospective study of 300 consecutive RRS are performed at the Royal Marsden Hospital in UK. We see the isolated stick, serous tubal intraepithelial carcinoma, found 7 cases out of 300. And among these 7 cases, out of 3 cases, 2 patients developed high-grade serous peritoneal carcinoma, diagnosed at 53 and 75 months after operation each. So careful follow-up is necessary in this group of patients. And nowadays, we believe that many ovarian cancers may start in fallopian tubes, not from the ovary itself. So we have an alternative strategy for preventing ovarian cancer in BRCA mutation carriers in their reproductive age before natural menopause. That is self-ingectomy first, and then delayed oophorectomy after natural menopause. This strategy also reduces risk, however, keeps hormonal function. Side opinions that the degree of risk reduction cannot be estimated and need 2 surgeries. Currently, several randomized clinical trials are ongoing on this subject. One of these is WISP trial, Women Choosing Surgical Prevention trial. In this trial, patients with BRCA mutation randomized to ISDO, interval self-ingectomy, and delayed oophorectomy arm, or RRSO. The interim result was presented last year at SGO. In ISDO group shows better physical quality of life compared to RRSO group. The next and final item is PARP inhibitor. In October 2017, the NHIS Korea approved and covering the cost of olaparib maintenance therapy in platinum-sensitive recurrent setting. And also recently, last August this year, first-line maintenance setting also approved. We have 3 kinds of PARP inhibitors available in our daily clinical practice: olaparib, rucaparib, and niraparib. In Korea, only 2, olaparib and niraparib, are available now. And I would like to briefly review the SOLO 2 and 1 trial. In SOLO 2 trial, platinum-sensitive recurrent setting, olaparib maintenance showed improved median progression-free survival, 19 months versus 5.5 months. The hazard ratio was 0.3. And we checked the real-world experience of oral maintenance in the same setting as in SOLO 2 in Korea. 4 institutions joined this study. And we found that the effectiveness and safety of oral maintenance in a real-world setting were consistent with those reported in the SOLO 2 trials. It's our real-world experience. And maintenance of Ovary was also tested in the frontline setting in the SOLO 1 trial. After protein-based chemo, if CR or PR is achieved, patients randomized to Ovary 300 milligram POBI or placebo up to 2 years or until disease progression. In 2018, at ESMO meeting 2 years ago, the SOLO 1 PFS result reported. At 3 years, 60% of patients randomized to Ovary were progression-free. But in the placebo arm, it was only 27%. It's a very striking difference. And this year's ESMO meeting, 5 years follow-up data reported. Still, 48%, half of the patients are progression-free still. The effect continued after the 5 years. So, and we believe some portion of these patients are cured. So nowadays, PARP inhibitor maintenance therapy in at least BRCA-mutated patients is mandatory in the frontline setting maintenance. In summary, for patients with ovarian cancer, BRCA gene test and or NGS cancer panel testing is essential for the patient and also for her family member. And for germline BRCA mutation carriers, RRSO is the current standard of preventing ovarian cancer. However, bilateral sampling followed by delayed oophorectomy may be an alternative risk-reducing strategy. And PARP inhibitor is nowadays should be used one as a maintenance strategy in ovarian cancer treatment, preferably as a first-line measure. And lastly, I would like to advertise the ASGO, Asian Society of Gynecology Oncology Workshop, which will be held on 19 to 20 December this year. It will be a virtual meeting also as the AOS meeting. Thank you so much. Stay well and stay healthy.
Good day, everybody. Thank you to Asian Oncology Society for the invitation. In this session, I would like to present about the current and future direction of radiation therapy for cervical cancer. And this is the outline. Cervical cancer is one of the most cancer incidents for women in the world among Asia. As data from GloboCan 2018, cervical cancer is number 5 for the most cancer in Southeast Asia. And in Indonesia, cervical cancer is number 2 for the most cancer incidents. And for the incidence and the mortality for cervical cancer, Southeast Asia is the region with the most incidence and mortality among Asia. And for the distribution of cervical cancer staging, in our department, almost 60% patients come with locally advanced stage. Stage 3B and 3C are the dominant stages. So how about the role of radiotherapy in cancer treatment? We know that the modality of cancer treatment consists of surgery, systemic therapy, and radiation therapy. Based from multiple studies in a lot of countries, radiotherapy has an important role for the treatment of cancer patients with more than 50% cancer patients need radiotherapy in their life. How does radiation therapy work, and how does radiation therapy interact with cells? There are two ways. First, the indirect way. The radiation interact with water in cells in our body to make free radicals, and this free radical will cause damage in the DNA. And the second way is the direct way, where the radiation directly damages the DNA. From these two ways, indirect way is the common ways, about 70% compared to the direct way. And the type of DNA damage are double strand break, single strand break, base damage, and cross-link damage. And the method of delivering radiation therapy to the patient are with external beam irradiations and brachytherapy, which the source placed directly to the tumor by using spatial applicator. And this is the role of radiation therapy in cancer as a definitive treatment, as an adjuvant post-surgery treatment, and as a palliative treatment. And the principle of radiotherapy is to give as much as radiation dose to the target mass and as low as possible radiation dose to the normal tissue surrounding the cancer. We can see from the therapeutic ratio here, there are two curves. The solid curve is the probability of tumor control, and the broken curve is the probability of complications. We need to get as far as we can for the distance between these two curves. And how is the strategies? There are several strategies that we can approach. First is by using high technique of radiation. Second, by using combination with systemic therapy. And three, using high linear energy transfer or particle such as proton or carbon ion therapy, but it is not commonly available in low middle income countries in Asia. And this is the technological progress of radiation therapy on cervical cancer. Radiation therapy delivered to whole pelvic to cover local and regional lymph nodes. In the old time, we use 2D conventional radiotherapy technique, where the beam is from two-way, from the anterior and from posterior. As technology developed, the technique become 3D conformal therapy, which is CT-based image acquisitions. The beam is from four ways: anterior, posterior, and lateral. And by the development of the technology, and we have intensity modulated radiotherapy, where we can sculpt the dose to the tumor. When we can also escalate the dose for the tumor higher than the surrounding area, and then the beam is from many way. About staging of cervical cancer is based from FIGO, where the latest was based on 2018 FIGO staging, where the use of imaging become more essential. You don't have to memorize all these staging, because there is a very nice app for FIGO staging of cervical cancer developed by IAEA, International Atomic Energy Agency. In the treatment of cancer, we need guideline. We can revert to NCCN guideline for cervical cancer already based on 2018 FIGO staging. And here in the NCCN guideline for cervical cancer, the role of radiation therapy include in all of the staging, where in the early stage of 1A and 1B, if the patient is not eligible for surgery, so then radiotherapy has the role as definitive treatment. And the stage of 1B, 3, and 2A, radiotherapy has the role as the first line of treatment as definitive treatment. And also in the early stage, if the patient undergone hysterectomy, even though the surgical findings, there are negative nodes, negative margins, and negative parametric involvements, if there are risk factors such as lymphovascular space invasions, giving radiotherapy as adjuvant treatment is needed to be considered. In the stage of more locally advanced, such as 2B, 3, and 4, the concurrent chemoradiation therapy is the treatment of choice by using platinum-based chemotherapy agent. And then in the external beam radiotherapy is a CT-based treatment, which in the preparation, patient needs to do the CT simulator. And in the treatment, here are the target volumes that need to be in the field of radiation therapy, like such as gross disease, parametrium, and also the as well as regional nodes have to be included in the pelvic field of radiation therapy. And this is the dose prescription of the external beam radiotherapy. We give 40 to 50 Gray to the local regional of pelvic area, and then boost using brachytherapy 30 to 40 Gray in 2 to 5 fractions of brachytherapy. Besides international guideline with NCCN, every country should also have national guidelines. This is the Indonesian national guidelines for the treatment of cervical cancer from the Ministry of Health. As I have mentioned above that there are strategies to improve outcome for the treatment of cervical cancer, combination of radiation therapy with concurrent chemotherapy is the treatment of choice. Chemotherapy agents that use for concurrent treatment mostly is cisplatin, and also some using 5-FU. Cisplatin is platinum agents that work independently from cell cycles. And there are several cooperation between radiation therapy and systemic therapy. It can be spatial cooperation, where each therapy works independently, and the toxicities also occur independently. And the other cooperation is in-field cooperation, where the goal is the same, to improve local regional control. And this is we call radiosensitization effect from the systemic agents. As we can see here, for the cisplatin, it affects the repair process of the DNA damage after radiations. Cell can respond to DNA damage after radiation by activation repair mechanism, but the additional of cisplatin during radiation will interrupt the repair process and leading to cell death. And this is this study by Dr. Henry Keyes published in New England Journal back in 1999, show the combination of radiation with concurrent chemotherapy of cisplatin is better than radiotherapy alone in terms of progression-free survival and also for the overall survival in 4 years. And this is for early stage of cervical cancer, bulky stage 1B. And this is also systematic review from Swiss group shows that combination of concurrent chemoradiotherapy improve the outcomes for the locally advanced cervical cancer in more than 2,000 patients from 14 articles. And from this systematic review, conclude that concurrent chemoradiotherapy improve the therapeutic outcomes in locally advanced cervical cancer, despite increase in grade 3, grade 4 acute toxicities. And this is the use of IMRT. We can modify it with a simultaneously integrated boost, where we can boost the enlarged lymph node within the pelvic region in the same time as the radiation to the pelvic area, where we give the whole pelvic to the dose of 45 to 50 Gray. In the same time, simultaneously, we boost the enlarged lymph node to 56 and 60 Gray in 25 fractions. And the outcomes of this is simultaneous integrated boost has excellent outcomes. How about the using of the brachytherapy? Before we use 2D conventional brachytherapy, where after the insertion of the applicator to the cervix and uterus, we do the image acquisition by using C-arm. And from the C-arm image, we plan the prescription dose to the point A. And now we use the 3D brachytherapy with the CT base or MRI base, where patients after the insertion of applicators will undergo CT simulator, and then we can get the image from the CT simulator, and then we do contouring, and then we prescribe the dose to the D90 high CTV should between 90 to 95 Gray, and we can escalate the dose to HRCTV if the dose to bladder and rectum is within the constraint. And this is the preliminary survey of 3D image guided brachytherapy among the Asian countries, and it is safe and feasible for the high risk CTV to the brachytherapy 3D. And this is current situation in Asia, where the group of FNCA studies brachytherapy and combination of concurrent chemoradiotherapy in the pelvis, and the result is the is a combination of CCRT is feasible and effective for patients with locally advanced cervical cancer in East and Southeast Asian countries. And also this group of FNCA shows that 2 years of overall survivals reach 92.7%, which is a very, very excellent. And then for the locally advanced cervical cancer, using weekly cisplatin 30 milligram per square meter and paclitaxel at 50 milligram per square meter. And also this study show that long-term results have suggested that concurrent chemoradiotherapy is safe and effective for patients with locally advanced cervical cancer in East and Southeast Asia. And how about situation in Europe? This is the retro embrace study in 2016 led by Professor Richard Potter group in Vienna that aim image-guided brachytherapy for locally advanced cervical cancer and the use of dose escalation to the high-risk CTV. This study includes 731 patients from 12 countries, from 12 centers in Europe, show that the excellent local control in the early stage reached 98% in 5 years, and stage 2B in reached 91% in 5 years, and also the overall survival for the early stage 1B reached 83% in 5 years. And then followed by Embrace 2 study. The purpose of this study was to provide evidence-based recommendation for tumor dose prescription based on results from a multi-center patient series or retro Embrace study, this previous slide. This in the Embrace 1 study revealed that the CTV high-risk dose of more than 85 gray in 7 weeks provide a 3-year local control rates of more than 94% in the volume of 20 cubic centimeter, and more than 86% in the large size of 70 cubic centimeter. And followed by Embrace 2 study, which aim to prospectively validate the findings of the retro Embrace and the Embrace 1 studies, and to benchmark an excellent overall survival based on improved local, nodal, and systemic control, as well as reduction of morbidity and improvement of quality of life. These studies will include 1,000 patients from at least 30 institutions in Europe, and hopefully we will have the result in 4 years or 5 years from now. And how about the future perspective? Now is trending about precision medicine for cancer, where the treatment is based on the mutation genes found in each patient, and the treatment will be given accordingly. And are there any mutation signatures that represent resistant tumors to X-ray radiotherapy? This is our study. We studied a patient with a uterine cervical cancer with stage of FIGO 1B2. And the patients have 3-time recurrences after treatment in the period of 3 years. In the first treatment, she received surgery plus adjuvant chemotherapy. Then she had her first recurrence. Then she treated with external irradiation and brachytherapy. And then from the patient's cancer tissue, from the biopsy, we label them T1 for the treatment-naive tumor, T2 for this first recurrence after radiotherapy, and T3 for the second recurrence after radiotherapy. And these are the 409 genes that we do the analyze using the next generation sequencer. And the result is from 409 genes, we found 68 genes having mutated in either T1, T2, and T3. As we can see here, 3 genes, PIK3CA, KRAS, and SMART4 having mutated in all event T1, T2, and T3, shown in the red box. And there's the conclusion of our study that the KRAS and SMART4 co-mutation is associated with resistance of cancer cells to X-rays. And this mutation signature may help to predict the response of tumor to X-ray radiotherapy, which contributes to precision medicine. And this is the study on cervical cancer using immunotherapy, and most of them using single immunotherapy are in the recurrent cervical cancer or metastatic cervical cancer. And this is the ongoing trial using concurrent immunotherapy in combination with chemoradiotherapy, and use immunocheckpoint inhibitors such as anti-PD-1 and anti-PD-L1. So we hope to see the result in the next 2 years or more from now. And this is studied by our colleagues here in Cipto Hospital about the combination of radiation therapy and monoclonal antibody anti-EGFR for locally advanced cervical cancer, stage 2B and stage 3B. This combination using anti-EGFR in weekly infusion of 200 milligrams for 8 times, 1 times weekly, given for patient with the immunohistochemistry with the EGFR expression +2 and +3. And then the biopsy and blood sample were taken 3 times, baseline before the therapy, during therapy, and after therapy. And this study is to analyze the immunological response of MABHR3 administration combined with radiotherapy in cervical cancer. And this is the result where the ratio of your immune cell both in tumor tissue and blood circulation shows that the immune component of CD56, CD4, and CD8 is increasing compared to the control during therapy. And also, the study found that after 3 months after treatment, there are 100% complete response in the treatment group compared to the 63.6% in the control group. And how about the radiotherapy in the era of pandemic COVID-19? We do the screening for patients, the first screening at the main entry gate of the hospital, and the second screening is the trials in front of the Department of Radiation Oncology entry door. We're screening for 2 types of patients. First, the screening for patient ongoing irradiations, and then the second is the new referred patient screening. For the new patient, we are mandatory to have a rapid antibody test or rapid PCR swab test negative in order the patient can go to our department. And we also do the physical distancing in our waiting room and also the receptionist area. And then the staff are using adequate PPE. And then we clean the machine table after every patient. And then we do the routine cleaning to the office and the public area. And if the patient is suspected COVID-19 or positive COVID-19, and then the patient needs to have a emergency radiotherapy, so the staff using adequate PPE, using hazard materials suits, and then radiation is carried out at the last patient of the day, and then after irradiation, do the general cleaning and disinfection to the room. And for patient on brachytherapy, before start brachytherapy, patient have to do the PCR swab nasopharyngeal test negative first. And this is our national study regarding the COVID-19 treatment and era, and published in Green Journal. So the conclusion of my presentation is that concurrent chemoradiotherapy improved the outcome for locally advanced cervical cancer. And in radiation therapy, external beam irradiation followed by brachytherapy is the standard treatment of cervical cancer. And future study is needed to understand the molecular mechanism of cervical cancer as the basis of personalized treatment. Thank you for your kind attention. Thank you.
Thank you for inviting me to react to the lectures of first Dr. Kim from Seoul, Korea. He discussed very well in his eloquent lecture, Hereditary Gynecologic Cancer Management in Korea. He shared with us their system of testing as well as treating hereditary ovarian cancer. Unfortunately, not all Southeast Asian countries are gifted with the same insurance system like Korea. Majority of the Southeast Asian countries still do not have that financial capability to fund genetic testing as well as utility of PARP inhibitors or targeted treatments for patients who are supposed to benefit from the targeted treatments. Take, for example, in my country, in the Philippines, the testing using BRCA1, BRCA2, or homologous recombination deficiency status is still out of pocket for our patients. In fact, very few of our patients who are suspect for hereditary ovarian cancer will actually do the test when we request it in our clinic. Secondly, if a patient will be using Keytruda or olaparib, which is the PARP inhibitor that is likely to be licensed this December 2020 in the Philippines, it will also be in his or her own out-of-pocket spending. This is a very expensive drug and will be used for maintenance in the long term. Most patients may not be able to afford, and so again, it all boils down to the difficulty in finding financial support. We are aware that we have reached a lot of improvement already regarding the alternative treatments and management and diagnostics for ovarian cancer. This is a stage in the treatment of ovarian cancer where our patients will surely benefit. And as we progress, I believe the pricing for the testing as well as for the drug itself will likewise go down. And by that time, majority of the countries in Southeast Asia will be able to probably afford. Thank you very much for allowing me to give my reaction to the lecture of Professor Kim. My next reaction is regarding the lecture of Professor Nuryadi. He talked eloquently about the role of radiotherapy in cervical cancer. He mentioned in his lecture the role of radiation for locally advanced cervical cancer. That is very true because radiation is actually the mainstay in the treatment of cervical cancer for all stages. He mentioned that if ever surgery is going to be recommended, it is only in the early stages. Dr. Nuryadi enumerated the improvements in the rendition of radiotherapy for patients with cervical cancer, specifically the IMRT and the IGBT, which conforms with the anatomy of the patient and allows the decrease in the toxicity to the surrounding bowel or other viscera. Very important in his lecture, he was able to highlight also the benefit of radiosensitizers. The use of radiosensitizing drugs, specifically cisplatin, was already enshrined in the 5 landmark trials which were released in Feb 12, 1999 by the National Cancer Institute in Bethesda, Maryland. From then on, it has improved the lives of our patients by increasing survival to at most 35% higher before the radiosensitization use. He mentioned the landmark trial of Rose, but I cannot forget the trials of Peters. Remember that apart from cisplatin, they also use 5-FU, they also use misonidazole. There were other trials that came later. Specifically, I was part of the part 2 phase 2 trial for capecitabine, which is an oral 5-FU derivative that can be used together with the radiotherapy and may be extended in the adjuvant sequence, which you can read in my publication enshrined in the journal, The Oncologist. Indeed, we have reached the stage in the treatment of cervical cancer where we can perfect the response of tumor kill and at the same time avoid toxicities to the surrounding organs or structures in the pelvis and abdomen of the patient. I congratulate Dr. Nuryadi and his team. We require a very good radiation oncology complement in the multidisciplinary treatment of patients with cervical cancer. Thank you for allowing me to give my reactions regarding these two lectures. Thank you and good day.